All right, I think we're going to get started for this AUA webinar. I'm Toby Chai. I'm the chair of urology here at Boston University, where I am currently. And I am going to be the moderator for this session. We're going to have three speakers, which I will introduce. The topic we're going to discuss today is complexities and challenges in complicated urinary tract infections, an update for urologists. Could I go to the next slide, please? So the agenda for this webinar is there will be three talks. The first talk will be by Dr. Ackerman on the urologist's role in complex UTI prevention and management. Dr. Ackerman is an assistant professor of urology in the division of FPMRS and the director of research at UCLA. The second talk will be by myself on factors influencing antibiotic treatment of complex UTI. The third talk will be, so how do we manage ESBL, complicated UTI? And that will be presented by Dr. Jason Pogue, who is clinical professor in Department of Clinical Pharmacology at University of Michigan College of Pharmacy, and he's also the ID clinical pharmacist at Michigan Medicine. There'll be a concluding comment at the end, and we will answer questions that come from the audience at the end of these talks. So please feel free to jot them down and ask them at the end, or you can send them in through the Q&A function, or I believe the chat is also available, but digitally send it in and we will collate and present the questions and answers at the end of this, at the end of the talks. Next slide, please. Please note, this is a non-promotional webinar sponsored by GlaxoSmithKline and is intended for healthcare professionals only. The faculty speakers here have created their own content for this webinar. Next slide, please. So without further ado, Dr. Ackerman, could you get started, please?
Absolutely. Thanks, everybody, for being here. So we're going to talk a little bit about the role of the urologist in complicated UTI management and prevention. Can I have the next slide, please? So I think I'll just start off by saying, when somebody asks me what the role of the urologist is in complicated UTI, my gut desire is to say it's not us. But I think that's really changing. And what we're really seeing is that as medicine is changing and we're seeing more and more patients with obstructive or anatomic diseases that are urologic in nature, things like increasing rates of nephrolithiasis and an aging population with more and more obstructive urologic diseases and all these kinds of things. And then you place that in the context of an aging population with an increasing frequency of things like immunomodulatory medications, rheumatologic diseases. People are living longer with more chronic illnesses, and we're seeing more biologic medications that influence the immune system in cancer and in a wide variety of other diseases. All of that comes together with just increasing rates of complicated UTIs in patients. And then we combine that with a global crisis in antibiotic resistance, as well as increasingly fragmented medical care in the United States, shortages in physicians and other providers, and just increasing options for patients to seek care. It becomes more and more difficult for us to manage these complicated UTIs in a well thought out way. And that means that I think urologists end up taking a larger role in how we approach complicated UTIs. And even if that's happening at the level of trying to have those discussions with patients before they happen, but also in interacting with a wide variety of other providers in terms of how we can keep people out of the hospital. Next slide, please. So why do we worry about complicated UTIs, or really kind of what is complicated UTIs? And these are really patients that have an increased risk over, say, your general population of a UTI, a cystitis, progressing to a more serious systemic infection. And there are two ways that you can kind of end up with infections of the upper urinary tract. One is through hematogenous spread, but I think what really is our place is where you get a cystitis, an infection, a localized infection of the bladder that progresses to a more systemic infection through ascending infection from the bladder up to the kidneys and then out into the bloodstream. Next slide. And the reason this can be really, really scary, as I'm sure everybody who practices in urology will know already, is that decline from localized cystitis to a very serious systemic infection can happen very, very rapidly. And these are the patients, the ones with anatomic sort of abnormalities or indwelling devices or immunosuppressive regimens. These are the patients in which that can be really, really scary and they have a much higher risk. So there are some good guidelines on how we should approach these patients that come from the EAU, the European Association of Urology, and they can kind of help you through how to approach the patient with a complicated UTI. Next slide. It tends to fall into two sort of phases. One is the sort of rapid response that should happen very quickly when you recognize that somebody is at risk of a more serious infection. And then there's sort of the secondary phase where hopefully we've stabilized the patient and they're doing okay and we got to move on to trying to get them past this. Next slide. So, what is the role of the urologist in that whole process? Because a lot of this stuff is probably going to happen in a hospital based setting, maybe before they've even called the urology team. And so I think we have some distinct roles to play, not necessarily in all of the supportive care that's happening early on in the hospital, but in really doing what we can to encourage in appropriate antibiotic use, encourage the best treatment of our patients, and prevent sequelae while still balancing that with not over-treating a large number of patients. So I sort of put this into three categories. The first is to recognize when antibiotic treatment may not be needed, and I think that's really important. Two is to fix the underlying problems, all of those sort of susceptibility factors that fall into the realm of urology that we can fix when we can do that. And then lastly, to support evidence-based practices for antimicrobial administration and improve antimicrobial stewardship. All right, next slide. So we'll focus initially on, okay, when can we recognize when antibiotic may or may not be needed? Next slide. So I mentioned briefly that rapid response, but often with patients who have, say, anatomic abnormalities, they may be in your office saying, "Hey, I've got my indwelling catheter, and I noticed today that it's a lot cloudier and smellier than it usually is." And those are kind of those situations where we can kind of prevent them getting into this algorithm in the first place. But if they come into your office and they're complaining of, say, fevers or subjective chills and other signs that there may be something more concerning, that's when we need to sort of make that early decision. And we can often end up doing that kind of from afar when you're called by, say, this patient with a chronic indwelling Foley or a nephrostomy tube or something indwelling, and you get a call from their primary care doctor, "Hey, I ran a urine culture and it's positive. What should I do?" And so this is really where we have to use our judgment. And so if you suspect sepsis, we need to get those patients into care where they can get really a high level of care and they can get it fast. So if you suspect sepsis, these patients need to get to a hospital where they can receive these immediate steps. Next slide. And so I tend to fall back on those objective criteria for sepsis, things that make me worried that somebody's going to decompensate. And that includes things like fever, tachycardia, increased respiratory rate. You can send somebody quickly for labs to try to see if they have an elevated white count, if they are altered in any way from their normal baseline state, or you're seeing other signs like an elevated blood glucose. These are sort of those early signs of sepsis that should absolutely get that patient from wherever they are to a more acute care setting. However, most of our patients don't really present like this. Next slide. And so the part of this algorithm that often gets sort of ignored is the side that says don't treat them. And so if we don't see those signs of sepsis, we don't see signs of concern that they're in danger of progressing, it is very reasonable to think about observation and, when possible, avoid antibiotic treatment. Next slide. And so the next thing that becomes really, really critical is not allowing, the fear and sometimes even the urine culture to be the thing that dictates how we take care of these patients. We all know that our patients that carry indwelling Foley catheters or even that are doing CIC that have an indwelling, device, a stent or other things are more likely to have a positive culture even in the absence of a true infection. And so using your judgment and not allowing the fact that somebody calls you and said, "I ran a culture because I just did and it's positive," to be the thing that dictates how you take care of these patients. We must use our judgment, and that's absolutely critical for good antibiotic stewardship. Next slide. So, a lot of that really has to be a judgment. We have to take the individual patients and we have to think about their unique situations and treat them appropriately. If this is somebody that lives a mile away, has a caregiver that can take them to the hospital if anything starts to go wrong, it's easier to let that patient sit and wait and just follow them than it is the patient that lives 3 hours away, 2 hours away from any hospital or medical care and has nobody to help them out if they were to become sort of altered or something like that. So we have to think about each patient's unique situation, how severe their symptoms seem to be, and then also kind of their personal history and the local history of antibiotic resistance. So if you know that there's a high resistance to fluoroquinolones in your community, and you're going to send that patient home on fluoroquinolones and they've got a personal history of fluoroquinolone resistance, that may not be a great idea. Whereas if you know that this patient has always had pan-sensitive infections while you're waiting for those results to come back, then maybe you feel a little bit more comfortable with that. So there's a lot of judgment that has to play into the decision about whether you feel comfortable to either keep them out of the hospital or just observe them without antibiotic management. And all of this comes back to the idea that a lot of the time in these patients, bacteriuria is not really going to be impacted by almost anything we do except resolving that underlying urologic issue, which we'll get into later. And so, using that judgment, having a good sort of sense of when you can and can or can't avoid antibiotics is really important. And so there aren't really great hard and fast rules for this. We just have to be better about not allowing that positive culture to dictate treatment. Next step, next slide. So, if you do have a patient and you are concerned about them and you're not necessarily ready to give them antibiotics, or maybe you are, it's still incredibly important to make sure that we obtain testing, urinary testing, before antibiotics are given. So, we need a urinalysis, we need urine and blood cultures, and we need imaging studies before antibiotics are begun. Because, again, often our patients who fall into this category of having complicated UTIs have a bunch of other comorbidities that also could be contributing to changes in their baseline status. And so in order to actually treat them appropriately, and this means doesn't mean you can't give them antibiotics, but if that wasn't actually the problem, you'll never know unless we get these things early on. And this is hugely important to have in place for health systems in general, not just urologic offices, to make sure that we can treat these patients appropriately. Next slide. Part of that probably does include imaging studies, and ultrasound is an easy sort of bedside thing that can often be done in the emergency room. But if that's not adequate, or if not telling you the answers that you need, CT is the next best thing to try to look for anatomic or other sort of source identification, trying to identify abscesses, hydronephrosis, obstructing stones, those sorts of things. Next slide. And so again, there's sort of multiple aspects of how we take care of these patients, and really only one of which ends up being the role of the urologist. Obviously, for patients coming into the hospital, we need them to get supportive care, fluids, oxygen, monitoring, all of those things, but that's often not where we play a role. And they may also, require adjunctive support, things like blood sugar control or management of their hypertension, other things like that if they have pain for any reason. These are helpful things to help allow you to see what's going on and make better judgments about how to take care of the patient. Our real role, though, is much more in cause-directed treatment. And that means both treating the source of the possible infection and doing what you can to eliminate that focus of infection by intervening for things like obstruction or other types of or indwelling devices, changing those out, trying to address what could be placing the patient at increased risk. Next slide. And what we're probably all aware of is that often what happens is that the patient ends up with their primary care doctor or in the emergency room, and all of these early steps happen way before the urologist is even called. And so we often come in a little bit later when it comes down to, hey, they have a catheter, should we change it? And we end up playing a little bit of a different role. Next slide. Excuse me. So that gets us to sort of the next thing in the list of what is the role of the urologist. And that really, I think, is where only we can play this role. And that is that our biggest job, I think, in these patients is to fix the underlying problems where we can. And if there is a patient who has developed urosepsis with a cause that is either obstructive or structural, and we can intervene on that, that is where we need to play the most active role in the management of these patients. Next slide. So part of that may include sort of a pre-step, which is doing the right thing for these patients when we're intervening with them. So making sure if we are taking care of a stone, that we provide the appropriate perioperative and periprocedural microbial prophylaxis. And what I will say is that everybody thinks that it's very, very, the sort of logical thinking, I guess, is that, that means more antibiotics before and around procedures, but it's actually not true. There is increased risk of infections after procedures when you do them inappropriately. So we want to do them at the right times, like before stone surgery, but not at the wrong times. There's no reason to give antibiotics before, say, urodynamics, uncomplicated cystoscopy. These are things where you can leave somebody without antibiotics and it actually improves their rates of post-op, meaning it has lower rates of post-operative UTI or post-procedural UTI when you treat them the right way, which is not giving them when they're asymptomatic. And so we want to use antibiotics when they're indicated, not when they're not indicated. Next slide. But our biggest role is managing those urogenital complicating factors. Next slide. And those are the things that are, say, obstructive or structural in nature. So obstructing stones, obstructing benign prostatic hyperplasia, neurogenic bladder that doesn't empty, a structurally abnormal bladder, solitary kidney, urethral obstruction, all of these things. In that moment where somebody is looking acutely sick, our job is to decompress, to drain, or to remove a device, and do this as minimally invasively as possible, replace devices if necessary, but to not plan giant surgeries. We want to do what we can to allow any source of infection to drain and get out of that patient's system, but we want to avoid larger surgeries. Next slide. And I don't need to go through everything on here. Probably most of you as urologists will be very familiar with what we do in each of these circumstances. Abscesses, drain them. Hydronephrosis, drain them. Ureteral calculus, drain around them. We basically need to provide a place for the urine to go so that when the body is trying to fight that infection, it's not focally stuck in one spot. We allow it to drain. Next slide. And so that takes us to the last thing on that list, which is evidence-based practices to improve antimicrobial stewardship. And Dr. Chai, I think, is going to take us a little bit more through this. Next slide. And as we unfortunately know, a lot of the times that we encounter anatomic, structural, functional obstructions, these sorts of things are not always easily fixable. And so we have to sort of have that familiarity with when is the right time to treat empirically, when is the right time to not treat. And so I'm going to allow Dr. Chai to take us through that a little bit further in terms of the indications and appropriate antibiotic management.
Thank you, Dr. Ackerman. So I'm going to be talking about actually using antibiotics. But before I start my talk about factors influencing antibiotic choice, I wanted to actually amplify what Dr. Ackerman had said about urologist's role in complicated UTI, because we often think that, treating with antibiotics is not too difficult of a decision, and it's really not within our realms. But it is really linked to what we do every day. And I wanted to this happened to me literally a month ago, where a patient that was in our practice had a history of kidney stones and presented with another renal colic episode in the emergency room. And the judgment part is really hard to be able to exactly know. It's like this index of suspicion. This particular patient was in for renal colic, had like a 5 millimeter distal ureteral stone, but was not uroseptic yet. Did not have a fever, but the white count was like mildly elevated. She was nauseated. And I looked at her history. 9 months ago, one of my partners treated her, but she had urosepsis with that renal colic episode. I actually just, again, I don't know. It's better to be lucky than good. I said, I'm not going to wait to see if she's really infected and observe. I just took her to the operating and put a stent in. It was in the middle of the night. It didn't matter. What came back later was quite interesting. Her blood cultures checked in the emergency room that night when I was on call, came back positive for E. coli. So I just lucked out, did not wait till she developed a full-blown SIRS, and then everything is going to be a big rush. But I used the prior history of her having an episode of urosepsis with a stone previously. So yeah, she got antibiotics for her complicated UTI, but the urologic decision to go ahead and drain her sooner rather than later with no real, it was just a index of suspicion, and her past medical history was really important. So now focusing on a different topic altogether is antibiotic selection. Next slide, please. So as I was putting this talk together, I'm glad that we have different parts that we're talking about, but I thought I should just define what a complicated UTI is. We've been talking about it, but this is a laundry list of what would be considered a complicated UTI. We heard about structural and functional abnormality in GU tract. So if you have that and you have a UTI, it's a complicated UTI. Any male with a UTI is a complicated UTI. And that's because of the anatomic connection of the reproductive tract with the urinary tract, leading to increased risk of developing prostatitis, orchitis, epididymitis. Fevers, sepsis associated with UTI is complicated. Any kidney stones that the patient has at the time of a UTI would be considered a complicated UTI. Known urinary tract obstruction, any catheters in the urinary system, not just indwelling urethral catheters such as a Foley, but suprapubic tubes, PERC nephrostomy tubes, PERC nephrostomy ureteral catheters, indwelling ureteral stents. Any pyelonephritis is a complicated UTI. Any woman that's pregnant with a UTI is a complicated UTI. And we heard discussion about immunocompromised host. Next slide, please. So what are the factors that influence how we select, antibiotics? We also want to know how long to treat someone with antibiotics. And, we are in an age of increasing multi-drug resistant microorganisms. And we have to be aware of that because that's going to influence our selection of antibiotics. And then we'll talk a little bit about the microbiology data that has been seen in some studies related to antimicrobial resistance in patients with complicated UTI. Next slide. So I think these are the different domains that we should all think about when we try to figure out what antibiotic to use. Patient-related factors, age, sex, medical history, any underlying medical conditions. Diabetes is obviously a large risk factor. I'll throw another little, I call my own experience of dealing with SGLT2 inhibitors that we see many patients on, which mechanism of action necessarily results in glucosourea, 3+ glucose in the urine. And I often wonder when we're doing, surgery, elective surgeries like ureteroscopy, stone treatments, or doing TURs on patients who are on SGLT2 inhibitors, whether we should stop them before the surgery to reduce glucose in the urine. Any urinary tract abnormalities, immunocompromised state all these factors may require a different approach. Looking at symptoms and urine cultures, both obviously the current one that you would be obtained when they're suspected of having a complicated UTI, but also prior cultures as well. The importance of doing a thorough history and physical cannot be understated. Um, the emergency room is both our friend and our foe sometimes. And I think physical exam is still an important role for urologists. Although the emergency room will probably have already a full body CAT scan by the time we get called, I still think an exam is important even when imaging has been obtained. Certainly the antibiogram in your community is really important. So you get a familiarity of the resistance pattern in the different pathogens that have been cultured out from urine specimens in the hospital. And then, for complicated UTI, there's a more potential variety of microorganisms. And sure, E. coli is still going to be high on the list, but you see these other organisms such as Klebsiella proteus, Enterobacter, and multi-drug resistant organisms. Next slide. So here are some classes of antibiotics that are commonly used for complicated UTI. Fluoroquinolones. But again, we do see increasing, incidence of resistance to fluoroquinolones. And in some communities, the fluoroquinolone resistance can be up to 20%. Trimethoprim, sulfomethoxazole, or Bactrim. We use it a lot, certainly for uncomplicated UTI, but again, can be used for complicated, but the resistance is in some communities also in the 20% range. Beta-lactams with the lactamase inhibitors can be also utilized, such as amoxicillin clavulanate, the beta-lactamase inhibitors. And then carbapenems could be thought of also for the cases where there's multi-drug resistant organisms. Next slide. So duration of antibiotic therapy and follow-up, there's the thought of how long is the appropriate duration of antibiotic treatment, and 7 days seems to be this time period that most people would think of treating complicated UTI. Although there's been some studies, meta-analysis studies, that found that there's no difference between a shorter course versus a longer course treatment, longer than 7 days, specifically for pyelonephritis. There's considerations that one must obviously take into account about the duration of treatment. And the duration would be extended if you can't control surgically or percutaneously any aspect of the urinary tract that's abnormal. Next slide, please. So risk factors of a patient harboring a multi-drug resistant UTI. Certainly a history, a microbiological laboratory testing history of having NDR pathogens in the past, prior hospitalization, prior surgeries, prior treatment with broad spectrum antibiotics, or contact with areas that have high prevalence of multi-drug resistant organisms. Next slide. So here's a challenging situation. You have a patient that grows out a multi-drug resistant organism that is only susceptible to IV formulation antibiotic. But the patient is not sick enough to require hospitalization. I think I've faced this situation not too many times, but enough to know that I ring up my infectious disease colleague to get a consult from them. Next slide, please. So this is the last slide in my section here, and this is just a microbiology laboratory data showing that patients who present to the emergency departments with complicated UTI have frequent NDR in their urine, and it's resistant to fluoroquinolones, Bactrim, or even nitrofurantoin. So there is definitely a need because of this increasing NDR for complicated UTI for have treatment alternatives. And we do need tools to stratify for antimicrobial resistance risk to better guide empiric treatment before the culture results are back. So I will turn this talk over to Dr. Pogue at this point.
Thank you so much, Dr. Chai. And I want to start off by thanking both you and Dr. Ackerman for great talks. As an infectious diseases pharmacist, hearing urologists talking passionately about optimal stewardship of antibiotics makes me really happy. So thank you. And I'd like to thank the audience for being here. Again, optimizing antibiotics is my life. It's just a small part of what you do, so I appreciate your time. And I think Dr. Chai did a really nice job of talking about this increasing problem of drug resistance in complicated UTI and pyelonephritis, even in patients who are presenting to us from the community. And one of the probably the most alarming things that we've seen is this introduction and real rise and spread of ESBL producers causing complicated urinary tract infections. So extended spectrum beta lactamase producers. Basically, when those isolates are present, all of your beta-lactams short of the carbapenems are out. And so what I want to talk about is how do we manage these patients? What are some strategies we can use? And you might be thinking, Jason, ESBL, carbapenems, I'm going to have ID involved. Dr. Chai just nicely brought that up. Why are we talking about this? And I think that's fair. First and foremost, I agree. I think ID should be involved in these cases, and carbapenems are the long-standing drug of choice for these patients because it's shown the highest efficacy data. But there's an issue with that, right? And there's really two issues, in my opinion, with just giving everybody carbapenems. First off, currently speaking, the only carbapenems that we have are intravenous in nature, right? If we have a patient who's otherwise able to be home, you'd hate to either admit them to give them, to be able to give them, admit them to give them IV antibiotics or have them get outpatient antibiotic therapy. And then secondly, if you give carbapenems across the board to everyone, then you worry about perpetuating the problems with carbapenem resistance. And so what becomes really important is knowing, are there potential other avenues that we can look at in these patients? And as urologists, I think this is really important. So that's what I want to talk about here today. So next slide, please. So one thing that's really awesome today is that a couple of years ago, the Infectious Diseases Society of America, or IDSA, they came up with guidelines for the treatment of gram-negative resistant organisms. And if this is at all of interest to you, I would encourage you to take a look at this document. It's available on their website, freely available. But they walk through all the different resistant types of organisms that we deal with and kind of give you best practice, evidence-based therapeutic recommendations. And importantly, with the supporting literature behind them. And interestingly enough, as it relates to my presentation today, one of the questions, as you can see, is what are the preferred antibiotics for the treatment of pyelonephritis or complicated UTI caused by ESBL-producing Enterobacterales, meaning organisms like E. coli, Klebsiella, and Proteus. And while carbapenems are a big player, and you see them highlighted under in blue there, I do want you to see what's first, what's listed first. And that's that, if possible, trimsulfa and the fluoroquinolones should still be thought of as first-line therapies. We know these are effective drugs for treating complicated urinary tract infections and pyelonephritis. And if the isolate ends up being susceptible, and your patient can tolerate these drugs, they don't have any drug interaction concerns, or they're not particularly of concern for some of the side effects like hyperkalemia with trimsulfa, we need to be thinking about these drugs. So we're going to come back to that in a second, but often you can't use those drugs, and that's why carbapenems become the mainstay. But one thing I also want you to see on this slide is look what's underlined at the bottom in green. there's an alternative option of aminoglycosides. And I actually we're going to talk about that a little bit today as we think of potential alternative therapies that we can give to these patients. Next slide, please. So if you saw that list, there's kind of like an elephant, right? You notice what I didn't talk about was a drug we commonly think about for urinary tract infections, which is nitrofurantoin. And I also didn't talk about oral fosfomycin. And that might on the surface seem a little bit odd because when you talk about E. coli, which is still our #1 pathogen, and even ESBL producing E. coli, nitrofurantoin and fosfomycin retain great in vitro activity. They're much lower in their activity against some of those other pathogens like Klebsiella and Proteus, but when it comes to E. coli, very active drugs, and certainly things that when we're thinking about urinary tract infection treatment, it's stuff that we're very comfortable with, we're very used to using. And so why isn't it on that list? And I think from a pharmacology standpoint, as a pharmacist, I think it's always important to drive this point home, is what it comes down to is that even though it's kind of our drug of choice to use something like nitrofurantoin for cystitis or lower urinary tract infection, the treatment paradigm changes when you're talking about a complicated UTI or pyelonephritis. And the picture on the left side of the screen really says it all. When you talk about treating cystitis or a lower urinary tract infection from a pharmacologic standpoint or a pharmacokinetic standpoint, really the only goal with your therapy is you want high renal elimination, so you get high concentrations in the urine, because it's really thought that those bladder concentrations are reflective of efficacy. And both nitrofurantoin and I would say to a lesser degree fosfomycin get pretty good concentrations in the urine. But when you start talking about some of the infections that Doctors Ackerman and Chai talked about, things like kidney infections or infected stones or abscesses, it's not that simple. It's not just urinary concentrations in that situation. In that scenario, you need systemic concentration into the bloodstream, and then you need the vasculature to penetrate that site of infection, similar to what you would think if you were treating a lung infection or a skin infection. And the thing to know about nitrofurantoin is that while it might get really good urine concentrations, the maximum concentration in the blood, again, you're only given 100 milligrams a couple times a day, it's actually less than 1 mic per milliliter. So it's really insufficient. Similarly, fosfomycin, think about how we give that drug for cystitis. Most common use is 3 grams times 1. So a 3-gram dose, only about a third of which is bioavailable, and a one-time dose. So you're only giving really 1 gram of that drug systemically. And just to put that into perspective with respect to fosfomycin, if you look at the bottom right side of the screen, there's actually an intravenous form of fosfomycin that's available as well. And it was actually studied in complicated urinary tract infections and did fantastically. But here's the kicker. It was a 7-day course of 18 grams a day of this drug. So if you do the math, that's 126 grams as opposed to the 1 gram you're giving when you give an oral dose. And so you're literally giving less than 1% of what has been proven to be the efficacious dose. So the reason you don't find these drugs on a complicated UTI list, on a pyelonephritis list, is because to treat a more systemic infection, you just don't get sufficient concentrations. So go to the next slide. And then if you remember back to a couple slides ago, what was first on that list from the Infectious Diseases Society of America? It's trimsulfa and fluoroquinolones. Again, as we talked about back then, these are great options for treating urinary tract infections. They have a proven track record. Again, they're orally available, which is what we would love to be able to do, right? Because as Dr. Chai gave us in that problematic scenario is, what happens if I can't give an oral drug? There's a lot of bad stuff that you have to do in order to get patients an intravenous drug, either in the hospital or an outpatient IV therapy. So these drugs are things we'd want to use, but there's one real big catch, and it's shown on this slide. So if you look, what I want you to pay attention to is what's highlighted in red. So what you're looking at on this slide are about 3,000 ESBL producing isolates in North America from 2020 to 2022. And you're looking at the percent of those that are susceptible to either trimsulfa or the fluoroquinolones. And here's really where the rub comes into play. When ESBLs are present, again, these are beta-lactamases that will inactivate our beta-lactam drugs. They often travel with resistance mechanisms to the quinolones and Bactrim. And as you can see here, only about a quarter to a third of isolates are going to retain activity of one of these drugs. So while that's good for treating those third or quarter of patients, it's not something that we can rely upon empirically. So while this is still a good and preferred option if we know susceptibility, it's unlikely that we're going to see that routinely, and certainly susceptibility isn't good enough to use that as empiric therapy. And that's why, again, the tried and true drug to give to these patients are going to be the carbapenems. But the question is, is there anything else we can do for these patients to limit carbapenem use, knowing the problem that comes with overuse of those drugs? Can you go next slide, please? And I'd like to propose to you that maybe there is something that we can do, and that's the aminoglycosides. And so, again, aminoglycosides are known to be highly effective drugs for the treatment of both lower and upper urinary tract infections. The reason for that is a lot of people know that they get high concentrations in the urine, and that's why they're good for lower infections. But they also concentrate in the renal parenchyma. And so when you're dealing with a pyelonephritis, you get good concentrations at that site of activity as well. And there's actually some clinical data to support this. And so what you're looking at here is a drug you've probably never heard of. This is plazomicin. So plazomicin is a novel aminoglycoside. They tried to bring this to market probably about 10-ish years ago now. And the claim to fame of this drug is that it was a highly active aminoglycoside against Enterobacterales. In fact, from an ESBL standpoint, pretty much every isolate was susceptible to this drug. And so they were trying to bring it to market for that space. And so to do so, if you look at the left side of the screen, this is the randomized controlled trial they did in complicated UTI. They compared it to carbapenem, again, the gold standard of what we're talking about for dealing with an ESBL infection. And what you can see on the left side of the screen is cure rates were actually higher in patients who got the aminoglycoside, and this was driven by enhanced microbiological eradication. Importantly, if you look at the right side of the screen, because this was a global study, about 30% of patients actually were infected in this trial with ESBL producers, and the results were incredibly consistent. But you might be thinking, Jason, I'm not super concerned about efficacy with aminoglycosides. I'm more concerned with toxicity, in particular nephrotoxicity or damage to the kidneys. But what I want to tell you is that over time, we've got a lot smarter about using the aminoglycoside class. And we've learned that if we can limit durations of therapy to 5 to 7 days or less, and we give the drug more pharmacodynamically optimized, meaning giving it once a day instead of 3 times a day, you can really mitigate this adverse event. And in fact, if you look at the bottom of the screen, the AKI rates while on therapy in this trial were the same between the two groups, about 3 to 4%. Next slide, please. So you might be saying, that's all well and good, Jason, but you just said we don't have plazomicin. Do any of the aminoglycosides we have potentially give us a benefit in this setting? And so what you're looking at here are 3 aminoglycosides that should be familiar to you. Those are the ones we have in clinical practice. And what again, I'll bring your attention to the red, which is percent susceptible to these drugs. And as you can see, particularly for amikacin, we see pretty good rates of in vitro susceptibility. Over 80% of those 3,000 ESBLs are actually susceptible to amikacin. Next slide, please. But the question becomes is, in vitro activity is one thing, right? It's what us ID folk always talk about. Are there clinical data to suggest that if I were to do this, it's both efficacious and safe? And the answer is yeah. This is a really nice publication that came out of Tel Aviv, Israel in 2020. And basically what this study is based off of, in 2016, for a lot of the reasons that we've discussed so far, this institution in Tel Aviv, they prioritized giving aminoglycosides for the treatment of pyelonephritis for hospitalized patients at their institution. And so if you look at the left side of the screen, what you're basically showing is over the study period from 2017 to 2019, the kind of gradual increase in use of aminoglycosides. And basically for patients who had creatinine clearances greater than 30, they were able to get to a place where over half of patients were getting this empirically. And this was either gentamicin or amikacin in this study. And so they wanted to see what effect did this have on outcomes. So they did a retrospective propensity matched cohort study of over 2,000 patients, including over 700 who got either gentamicin and amikacin. And these were patients who had pyelonephritis with or without bacteremia. And just so you know, if you look at the patient population in this study, relatively old patients, average age was about 80. They were pretty sick. About a third of the cohort had bacteremia. So these are legit infections that patients had. And they looked at the outcomes of patients who got aminoglycoside versus the alternatives, which were largely beta-lactams. And what they were able to show was, at the very least, efficacy outcomes were the same, and there were some suggestions of superiority. And once again, look at that last bullet. AKI rates were not higher because they were giving short courses, once daily dosing of the drug. Next slide, please. And just so you know, it's not just Jason saying that this is a potential good option for our patients. What you're looking at here is the ID guidelines from the European group. And as you can see at the bottom, this is recommendations for third generation cephalosporin resistant Enterobacterales, which is essentially ESBL producers. And they say for complicated UTI in patients without shock, they recommend giving aminoglycosides. Next slide, please. And so just to wrap up, so how do I treat complicated UTI due to ESBL? Again, carbapenems do remain the drug of choice for most patients. But remember, there are limitations to giving that routinely. If we can give trimsulfa and fluoroquinolones because we want to be able to give oral therapies, so if we have an isolate that is susceptible, if we don't have drug interaction and side effect concerns, we should be thinking about that. And I would argue that aminoglycosides also have great potential for the treatment of ESBL complicated UTI. And with that, I'm going to turn it back over to you, Dr. Chai.
Thank you, Dr. Pogue. So I'm going to make a concluding remark here, show another couple set of slides, and then we'll open up to some of the questions that came through and have a discussion. Next slide, please. So we've heard that optimal management of complicated UTIs varied in the last years due to increasing complexity of patients, as well as finding more multi-drug resistant bacteria in the urine cultures. The urologist plays an important role in antimicrobial stewardship. We should intervene where we have a role in terms of correcting the structural abnormality or controlling the source surgically, appropriate implementation of the correct prophylaxis depending on the individual risk factors, identifying risk factors for multi-drug resistant organisms as a causative agent in UTIs. There are opportune and appropriate antibiotic treatment. This is a most important modifiable risk factor to reduce mortality and costs. Empiric first and then confirmed after culture and sensitivity testing. Certainly, I think you've heard all of us say that there is a need for new treatment approaches to avoid hospitalization when clinically feasible and to reduce length of stay. Next slide, please. So just so that we all know that there's both efficacy and potential adverse events. I'm not going to go over all of these, but each of the antibiotics discussed in the talk today have potential adverse events. For the quinolones, aminoglycosides listed there, as you can see. Next slide. As well as trimethoprim, sulfamethoxazole, fosfomycin, and pip-taz. So next slide, please. And then these are the side effects of ertapenem, meropenem, and the beta-lactams.